Hello, you guys. My name is Ashley Wyden, and today I will be presenting to you guys assessing different characteristics of subclinical atherosclerosis, which can focus on the treatment, gender, age, or race. So please stay tuned and enjoy my presentation. What is subclinical atherosclerosis? You may wonder. Well, it is an early indicator of atherosclerotic burden, and its timely recognition can slow or prevent progression to cardiovascular disease. Some individuals with subclinical atherosclerosis are the top priority for primary prevention. What are some symptoms of subclinical atherosclerosis? You may wonder. Well, people can suffer with chest pain, numbness, weakness in arms or legs, leg pain while walking, high blood pressure, or they can show signs of kidney failure. What causes subclinical atherosclerosis? Causes include smoking, high levels of fat or cholesterol in the blood, high blood pressure, elevated sugar, and inflammation from either arthritis, lupus, infection, or other diseases. Some evidence also show that it may be caused by the damage of the inner lining of the arteries where the plaque is located. The topic of my first article is blood pressure trajectories in early adulthood and subclinical atherosclerosis in middle age. The aim of this study is to identify the subgroup of individuals with similar trajectories in BP from young adulthood through middle adulthood, which characterizes those participants and the blood pressure trajectories. It also determines the independent association of BP trajectories from young adulthood to middle age with the presence of subclinical cardiovascular disease. The larger the changes in BP, the greater the lifetime risk of having cardiovascular disease. Blood pressure represents a major modifiable risk factor for cardiovascular disease. People that ingest large amounts of salts over time can cause systolic BP to rise because of their age, and these increases happen during middle age, which are also associated with cardiovascular disease. The method states the CARDIA study is a prospective cohort study designed to investigate the development of cardiovascular risk and diseases. 5,115 black and white women and men aged 18 through 30 were recruited from 4 urban sites across the United States. The urban sites included Birmingham, Alabama, Chicago, Illinois, Minneapolis, Minnesota, and Oakland, California. The participants followed up more than 25 years with detailed demographic, clinical data, and assessment for subclinical atherosclerosis. Subclinical atherosclerosis was quantified using the coronary artery calcification, which was measured at the year 25 examination. Blood pressure trajectories were modeled among 4,681 cardiac candidates, with the BP also measured at 3 or more examinations. Mid blood pressure was chosen a priori because it showed to have the greatest predictive utility of cardiovascular disease compared to other single measures of BP such as systolic blood pressure or diastolic blood pressure, pulse pressure, or mean arterial pressure. Mid-BP also allowed researchers to take into account the effect of both SBP and DBP. This is important amongst the younger cardiac population because diastolic blood pressure played a larger role in cardiovascular disease among young to middle-aged adults. In the statistical results, you are looking at 2 charts, and Table 1 specifically focuses on the mean of SBP and DBP and percentage of participants taking a certain medication at each study, which is examined by the mid-BP trajectory group. For Table 2, you have the demographic characteristics and risk factors of participants by mid-BP trajectory group, and it just specifically shows female, male, the race, education, have they smoked in their lives, their cholesterol level, are they diabetic, their BMI, and the coronary artery calcification score that's needed within this study. The discussion of Article 1 mainly focused on the 5 unique trajectories in mid-BP and SBP that were significantly associated with the presence of subclinical atherosclerosis later in middle age. Cardia study participants who had elevated BP levels throughout the study and those who had an increase in BP over time had the greatest odds of having a coronary artery calcification score of 100 HU or greater. More than at least 33% of U.S. adults have hypertension. African Americans and smokers are most likely to experience rapid increases in BP during the middle age, which placed the two populations at a higher risk. The effect or timing and change in BP on subclinical atherosclerosis may be important for risk stratification in the future. Numerous studies have found individual cardiovascular health metrics, including obesity, diabetes, and blood pressure. Studies are increasingly showing the deadly outcomes associated with the cumulative exposure to elevated cardiovascular disease risk factors. Increasing the proportion of children who reach adulthood in ideal cardiovascular health could be associated with the reduced burden in cardiovascular disease at a later age, and could also help achieve goals of improving the cardiovascular health of all individuals in the United States. To conclude the first article, blood pressure has been a well-known risk factor for cardiovascular disease for decades, and these findings can help researchers determine if an individual's long-term pattern of change in blood pressure starting in their early adulthood could provide any information about his or her risk developing coronary calcium. Prehypertension at a very young age, while having long-term exposure to blood pressure levels in the prehypertension range or higher, is associated with the coronary artery calcification score of 100 HU or greater. More research is needed to examine the utility of specific blood pressure trajectories and risk prediction for clinical cardiovascular disease events to explore the effect of lifestyle modification and treatments. What is atherosclerosis? Atherosclerosis is the buildup of plaque, which is a combination of cholesterol, fat, calcium, and blood elements on or inside the walls of your arteries. To sum all that up, you can just say that it's hardening of the arteries. There are certain approaches that can be used to treat atherosclerosis, such as statin therapy, which can have a slow or reverse progression of the disease depending on the intensity of the treatment. You can use aspirin, blood pressure medications, and if your provider wants you to try the surgery option, that's also a route to take. Article number 2 focuses on the cardiovascular health trajectories from childhood through middle age and their association with subclinical atherosclerosis. The aim of this study was to describe cardiovascular health trajectories for the first time from childhood through middle age, such as ages 8 through 55 years, and determine the association of these patterns with subclinical atherosclerosis as a measure by a carotid intermediate thickness in middle age. In 2010, the American Heart Association defined ideal cardiovascular health and set its goal to improve cardiovascular health by 20% while reducing cardiovascular disease mortality by 20% during the decade. A decrease in cardiovascular disease mortality have occurred since then, and many risk factors among adults have improved. Poor cardiovascular health among children may derail these improvements as they grow into adults with a significant chance of having cardiovascular risk. Single measures of cardiovascular health during adolescence and young adulthood is associated with the incidence of hypertension, metabolic syndrome, hyperlipidemia, and an increased burden of subclinical atherosclerosis. A certain assessment called the carotid intermediate thickness with the ultrasonography is a non-invasive measure of cardiovascular health disease risk and has been shown to more accurately identify individuals that are at a higher risk for cardiovascular disease than using major risk factors alone. The method stated that this study included participants from 5 different cohorts. Each cohort collected clinical measurements at in-person examinations and used questionnaires to collect data on lifestyle variables over time. Also, the study recruited 11,796 children and adolescents from whom the data were used for 10,451 during 7 risk factor screenings between the year of 1973 and 1993. More than 100 133 children were followed up during an adult examination between 20 to 37 years of age. The YFS included 3,596 children aged 3 through 18 years at the baseline in 1980, and data was used from 1986 onward, since this period was when glucose levels were first assessed. The cohorts were followed by the ages of 3, 6, 9, 12, 21, and 30. The data provides an understanding of cardiovascular health patterns from ages 8 through 18 years. Here we have 3 charts that are listed. The one to your nearest left states that the baseline characteristics and examination counts by clinical cardiovascular health score trajectory group. And if you look closely, it breaks down the characteristics as to what they're looking for. They're going by gender, which is female, the race of white, black, and other, the age mean, age group, the cohort, and then the clinical measures of the BMI, blood pressure, and the cholesterol level and glucose level. In the middle, the chart focuses on the characteristics and examination counts by clinical cardiovascular health score trajectory continued. And to the far right, the third chart focuses on association between the carotid intermediate thickness and clinical cardiovascular health score trajectory group. And it just specifically states the moderate, early, intermediate, late decline, intermediate, early decline, and it goes into depth about the baseline scores and how well they did on the CIMT ultrasonography test. The discussion for Article 2 focused on 5 novel and distinct trajectories in clinical cardiovascular health, which were scored among individuals aged 8 through 55 years of age. The cardiovascular health trajectories are associated with the level of subclinical atherosclerosis in middle age, independent of single cross-sectional measures of cardiovascular health, either baseline or the time of CIMT measurements. The groups beginning in childhood with poor cardiovascular health experienced more rapid declines in cardiovascular health, and they also had greater CIMTs and were more likely to have high CIMTs by middle age. Future studies should examine the timing and the causes for the decreases in the cardiovascular health score so that certain interventions can be designed to promote and maintain cardiovascular health throughout their lifetime. Numerous studies have found individual cardiovascular health metrics, including obesity, diabetes, and blood pressure. Studies are increasingly showing how daily outcomes are associated with the cumulative exposures to elevated cardiovascular disease risk factors. Increasing the proportion of children who reach adulthood in ideal cardiovascular health could be associated with a reduced burden of cardiovascular disease at a later age, and they also help achieve goals of improving the cardiovascular health of all individuals within the United States. Concluding Article 2, researchers found that maintaining a high level of cardiovascular health from childhood onward could be associated with reduced future burden of cardiovascular disease. Majority of all trajectory groups experience a major decline in cardiovascular health during childhood and adolescence through early adulthood. More research is still needed to determine the effects of targeted intervention, which is focused on preserving and promoting cardiovascular health to children at a higher risk of experiencing a decline in cardiovascular health. Relation between Articles 1 and Article 2. Both articles focus on the importance of treating and preventing cardiovascular disease. The articles go in depth about the findings that suggest the cause of cardiovascular disease and the age group which is most affected by atherosclerosis. Blood pressure is highlighted in both articles and seems like it is the primary cause that can lead to atherosclerosis. BP is most commonly found in African Americans, and African Americans was statistically shown in the articles to have the highest blood pressure. Each model in the articles demonstrated the incline of atherosclerosis and the decline of atherosclerosis. It usually starts at a younger age depending on the demographics and increase over time until adult years.